Good afternoon, my name is Dalton Klatt. I'm a nationally registered paramedic. I'm currently working EMS for Scotland and Moore County here in North Carolina. Today, for this class, we're going to be talking about your trauma patient assessments and what situations would you need to use this specific type of assessment, the things we're looking for in each stage of our assessment, as well as how to conduct a good secondary physical assessment to see if we can't find any additional signs and symptoms that may guide our treatment when assessing patients in trauma scenarios. I have here up on the board a couple of considerations we want to take into account, not only on trauma calls, but on any type of call that you might find yourself on in general. The very first one is scene safety. Now, scene safety is something you need to take into account on every single call that you go on, because at the end of the day, the most important thing that you can do on your shift is get yourself as well as your partner home safe. So we need to make sure that we have a safe scene before approaching any of our patients. Now, in cases of trauma, most of the traumas that we encounter will come from motor vehicle accidents. Depending on what type of county you work in, you may have a high crime rate. You may be seeing more of those assaults, shootings, stabbings, things like that. One thing that ties into your motor vehicle accidents are your hazmat situations, and or if you have industrial buildings within your county or area of operation. In motor vehicle accidents, an oil tanker could spill over on the highway, and you need to take important hazmat considerations on that call before assessing any trauma patients that you may have on the scene of that motor vehicle accident. Two, the second thing we need to consider is, do we need any more additional resources? Do we have enough hands or equipment on this ambulance to handle these trauma patients? So, do we need to request any additional EMS units, whether that be a supervisor or a whole nother transport capable ambulance as well? In some counties where you may not have access to a level 1 trauma center, do you need a helicopter or possibly a critical care ground unit? Do you need those additional medical resources to assist you on this call? Now, as we move into actually getting eyes on our scene and we gather our general impression, based off of that, is this going to be some kind of triage consideration? Are we going to need to grab our smart triage kit out of our ambulance and begin triaging these patients and directing any additional resources that we may have called to the scene to different patients on the scene of our patient trauma? Also, going along with the general impression, have we formulated a first thought, so to say, on these patients? Are they alert and oriented and talking to us? Are they alert and screaming in pain? That right there establishes a patent airway, which is part of our assessment that we'll go into. Just all these important considerations you want to keep in the back of your mind before actually even laying hands on a patient to do these types of assessments. So in EMS, we try to teach people using things that make it easy to remember. So in your trauma assessment, it's going to be guided by this algorithm right here called MARCH. M-A-R-C-H, MARCH. We're going to break this up into stages and talk about each one and also the treatments associated with that stage prior to going through an entire trauma assessment demonstration at the end of this lesson. So the very first one that we're going to talk about is the letter M up here. The MARCH algorithm actually originated from the United States military when they conducted numerous testing about what actually killed our trauma patients, in their case, their wounded service members. And what they discovered was M, which stands for massive hemorrhage, was actually the number one cause of death in their trauma patients. So anytime we come up on a trauma patient, the very first thing that we are assessing and treating on these patients is going to be any bleeding, or also known as massive hemorrhage. Now, bleeding is extremely important to manage and control in these patients because, as we've talked about before, we know what the blood does. Blood is the carrier of oxygen throughout your entire body. Without oxygen, tissues get ischemic, they get necrotic, and then they die. Oxygen is needed to supply all organs and tissue within the body to support life within those cells. And we need blood to move those tissues around. So the first thing we're assessing for is massive hemorrhage. Now there are two specific areas on the body that we are assessing for bleeding. The first one, which is pretty self-explanatory, is going to be our extremities. Our extremity hemorrhage is extremely preventable. And why is that? We have a tourniquet in the bag, right? We throw a tourniquet high and tight on that extremity, cinch it down, tighten that windlass, secure it down. In most cases, as that artery is as compressed against that long bone on that extremity, whether it be the humerus or the femur on your lower extremities, in most cases that will stop major flow of bleeding from the extremities. Now, the next place that we want to look at for bleeding is what's known as our junctional areas. Now, our junctional areas are described as anywhere on our body where our extremity, so our arms and our legs, meet our trunk. Now, there's actually 4 junctional locations on the body. One of them is actually often overlooked and not talked about. So, the first one, if we go from top to bottom, a lot of us like to work in a way that makes sense. If you work in your assessment from top to bottom, the first one that you're going to come to is the neck. So the first place that we're looking for is hemorrhage in the neck, down through the sides here, as well as on the back side. Any sort of hemorrhage, proximal or direct pressure is applied to that area to stop the bleeding, and we'll identify any other areas of massive hemorrhage on the body. Moving down, the next junctional area we're going to move to is the armpit, also known as the axillary region. So our armpit, medical terms, we like to use medical terms in this profession. They're widely accepted all across the world. Makes you sound like you know what you're doing. It's not the armpit, it's the axillary region. We should also know that from it is a location to take a temperature, mostly on our pediatric patients. But we're looking for massive hemorrhage in that axillary region. Moving down, as we get to our lower half, the third place we're going to look for is the inguinal region. Inguinal, meaning the groin, where our lower extremities come up into our pelvic girdle, right there in the groin area. That's going to be your inguinal region. And this fourth one I'm going to talk about is the one that is often overlooked, and this is what's going to be known as the subgluteal cleft. This is going to be the area up under your butt cheek on your rear, and that is known as the subgluteal cleft, the area under your butt cheeks. These are all areas where extremities meet the body, and massive hemorrhage coming from those areas needs to be addressed because, as we all know, arteries run long bones, and where they meet the trunk of our body, these are heavily trafficked areas by our body's vasculature. So, looking back, our extremity hemorrhage, how do we treat it? Tourniquets, and depending on the extent of the bleeding, can be sometimes treated by emergency trauma bandages, compression bandages, some people call them Israeli bandages, all those good things, as well as tourniquets. Throwing a tourniquet high on the extremity and or 3 to 4 inches above the side of the wound if you can actively visualize it initially. We can place that tourniquet 3 to 4 inches above, making sure we're not on a joint, making sure we're on viable tissue, meaning tissue that's not burnt or really bad abrasions exposing muscle or ligament or tendon tissue, making sure that tourniquet's on viable bodily tissue. Our junctional areas, these are areas that's going to be packed. Hopefully your agency is carrying some kind of hemostatic gauze so that we can place that onto the side of our bleeds in our trauma patients. And then once we run out of our hemostatic gauze, we can continue to fill that cavity with regular gauze to keep constant pressure on the side of that bleed. Now, an important thing to remember in your stage of massive hemorrhage is you can't treat what you can't see, and you have to go searching for these injuries, especially in your cases of GSWs or explosions, could be shrapnel. Sometimes these holes are very small, and we really have to get into the business of our patients, as I like to say. You have to get up in your patient's business, pull apart tissue, move extremities out of the way, roll your patients. You need to be able to visualize all of these areas so that we're identifying any type of massive hemorrhage that may be going on with these patients. And in order to do that, we have to do what's called trauma naked. Now, we use the term trauma naked to describe exposing our patients, right? Using our trauma shears to cut away that patient's clothing to expose the patient. Now, it's important to remember, while at the same time we are trying to save their life, it's not our job to put patients on full display in the eyes of the public. So, in the cases of our males, we may need to have them completely naked if we're still unable to identify the site of the bleed, but in our males, we can think about leaving their underwear on as long as we're making sure that we're checking under it, and then in our female patients, their underwear as well as their bra. We just need to make sure that we are getting thorough assessments done on these patients while also not embarrassing them and keeping their modesty about them. But massive hemorrhage is number one in our list because it has been identified as the number one threat to life in trauma scenarios. An arterial bleed can cause a person to bleed out and die within 3 minutes, depending on the extent of the bleeding. So it's important to identify and address this as early as possible and treat accordingly. So once we have moved past the M, or the massive hemorrhage stage of our algorithm, we've identified all the major bleeds and treated accordingly. The next thing we're going to move to is the A in our algorithm, which stands for airway. Managing and protecting our patient's airway. Now this stems off of the old acronym in EMS of manage your ABCs, but they didn't do a very good job of taking into account massive hemorrhage. So once we have addressed the bleeding in our patients, we now move to our airway management. So this encompasses two different things. The first one is going to be our obvious BLS intervention, which is our positioning. Positioning our trauma patients in a position to where they can maintain their own airway. Now, depending on the extent of injuries, we may have some other critical things to tend to, and we can move past our airway stage of our algorithm just by a simple positioning, whether that be a head tilt chin lift, or possibly having somebody else on scene hold a jaw thrust maneuver, or simply placing our patient in the recovery position and working off of that position. We may have some major respiratory or circulatory issues that may need to be addressed, and they can if we properly position our patient and they're able to maintain our own airway. Now, if that's not possible, where we can't maintain it just by positioning, we do have our airway adjuncts. So, when assessing this airway, we want to listen for any sounds that don't sound normal. So, coming up on our trauma patient, once we've addressed any major bleeds, we will come up to them, we will open the mouth, look for any obstructions, any sort of indications that there might be any sort of trauma to the airway itself. Is there any trauma to the neck? Is there any subcutaneous emphysema? Is there any airway sounds? Do we hear some audible wheezing? Do we hear a high-pitched tone of stridor? So those are all things to take into consideration when considering to place any type of airway adjunct, looking for trauma, listening for sounds, and looking for obstructions. So when it comes to our adjunct, we like to move least invasive to most invasive. So our two kind of interchangeables that we kind of see in EMS that are least invasive, they don't require anything other than a simple airway positioning to place as well as a measurement. We have our MPA and our OPA. And these are airway adjuncts placed into the upper airway, the MPA going through the nose, the nasopharyngeal airway, and then we have our oropharyngeal airway that can be placed into the mouth. Now it's important that we do a good assessment on this patient, right? We don't want to place an OPA in a patient with a gag reflex. We might be able to go with the MPA as long as it's not contraindicated. In our more unresponsive patients, we may need to get a quick airway protection. Now when I say protection, I mean something that we can attach a BVM to. We don't necessarily have to worry as much about a seal. It doesn't protect the airway from aspiration or anything like that, but we also have our biads, whether that be a King LT, an iGel, anything like that, a blind insertion airway device. These are things that are placed into the patient's mouth for a temporary type of airway. As we move down into the line, we have our endotracheal tubes, our ET tubes. Those are placed past the glottic opening of the patient and directly into the trachea. And then last but not least, we have our emergency airway, which is our surgical crike. It's important to get a good airway assessment of your patient prior to placing any of these adjuncts. Patients who are just unresponsive after bonking their head probably don't need a surgical crike, but somebody that was standing over a piece of heavy machinery, or let's say a barbecue grill, and there was a sudden explosion, and now we have some burns, some soot marks around the mouth, and some stridor. Depending on the swelling of the airway, we may need to consider either an endotracheal tube or a surgical crike. But selecting these airway adjuncts all comes from a good airway assessment, which we'll demonstrate later in this lesson. We've now reached the R part of our assessment, which stands for, forgot how to spell it now. Respirations. So once we have identified and treated any massive hemorrhage, we've secured an airway for our patients or come to a point where we are comfortable with our patient maintaining their own airway, we now need to move to assessment and treatment for their respirations, that oxygen exchange going on in the lungs. So there's two major ways that we assess our respirations. We're going to be first assessing and auscultating lung sounds. This actually involves exposing our patient's chest, listening to the lung sounds in their body. Are we hearing wheezing? Do we hear any rales? Do we hear any audible stridor coming from the upper airway, making itself down to the lower airway? Do we have absent lung sounds? Do we have unequal breath sounds when comparing both sides? Do we have the same sound at the apexes as well as the base? These are all things that are assessed through auscultation. Now, as far as the hands-on part of this assessment, we are getting hands on our patient's chest and looking for any types of holes that may be found in the chest wall. Now, good landmarks for this are neck to navel. So we have our manubrium right here, just above our sternal notch, and then we have our belly button, our navel. Anything in this area going across the front of the chest, as well as pit to hip. So anywhere in the bottom of our armpit going down to our hip, this is all considered our chest cavity. And what we're doing is we're exposing our patient, we're pulling apart that tissue and looking for any kind of holes that may have disrupted the negative pressure that exists naturally inside the chest. So we have what's known as the bear claw maneuver. We bear claw. We make the bear claws with our hands and we pull it apart. We're looking for holes inside the chest. Now, if we were to find a hole in the chest, we may want to become a little more suspicious of our pneumo and or hemothoraxes going on inside the chest that may progress to a tension pneumothorax. Actually, those lungs building up more and more pressure inside the chest cavity, that it actually compresses on the heart and the heart cannot beat effectively. It doesn't gain any preload and it has to pump against all that pressure to push blood out until it's unable to. So another thing that we want to assess along with our lung sounds, remember I talked about unequal breath sounds, is we also want to assess the rise and fall of the chest wall itself. Now you'll see a better representation of this later on in the demonstration, but basically what you're doing is getting hands on the diaphragm and actually looking up towards the patient's head and ensuring that we have adequate and equal rise and fall of the chest on both sides. We want to make sure that both lungs are working in the same capacity, that we don't have an issue with one side of the chest rather than another. So that moves us, once we do our assessment, that will guide our treatments, like I said earlier. So there's two major treatments that you may be applying to your patient in the respiration stage of your March algorithm. First one of that is going to be your OCDs, your occlusive dressings, otherwise known as chest seals. These are essentially very large, non-porous, meaning air can't move through them, stickers. They're essentially non-porous stickers that we would place over any holes inside the chest that may be introducing positive pressure into our naturally negative pressurized chest cavity. Now, say that we weren't able to get a chest seal and cover up that hole in time. We may have a buildup of air inside the chest. This can also come from blunt force trauma to the chest, say a sudden deceleration in an MVC, and our patient hits the steering wheel, and we now have a collapsed lung, where that lung tissue is actually punctured and can no longer inflate and deflate. We may have a buildup of pressure that may need release, in which case we would use a NCD. Some people call it an NDC, a needle decompression of the chest. I use NCD, just what I was taught, coming from a military background. I use NCD, needle chest decompression. Now, this is a 3 1/4, 14 gauge needle that is applied either through the second intercostal midclavicular line, placed into the chest cavity, or the 5th intercostal anterior axillary line over here on the side, either side, depending on which side is affected, to release some of that excess air and try to bring the chest down to a more negatively pressurized cavity. So, like I said, these treatments are going to be guided by our assessment. So it's important to assess for those holes using the bear claw method, assessing those lung sounds, and also assessing for adequate and equal rise and fall of the chest on both sides. So after we have conducted our respiration assessment, we move into C, which is circulation. Now, circulation is 3 pretty easy steps, and it's very easy to assess. So we're assessing how our body is properly circulating blood throughout the body. So the first thing that we are going to do is check our distal pulses. Now, this can be a pedal pulse, or this can be a radial pulse. Now, we all understand that pedal pulses are sometimes very difficult to find, even in a healthy individual. So more often than not, you'll probably be relying on a radial pulse to identify if the body may or may not be circulating a systolic blood pressure of approximately 90 millimeters of mercury. It's typically the rule of thumb. If somebody can maintain a radial pulse, they're typically maintaining a systolic blood pressure of 90 millimeters of mercury or higher. So this is just kind of a sign and symptom that we use to kind of identify, okay, where is this patient at? Because up until this point of our assessment, we've conducted no vitals checks, other than maybe assessing their respirations and level of consciousness. We don't have a blood pressure. This is where we get our, hopefully, systolic of 90 millimeters of mercury or higher, and we also can obtain some type of pulse rate. Checking that radial pulse over the course of 10 to 15 seconds. If you do it for 10, you multiply that number by 6, do it for 15, multiply it by 4, and that hopefully gives you your pulse rate. Now once we've done this, our treatments for this stage are pretty simple. This is where we establish our IV and or IO access to be able to push the next stage of our treatment, which is fluid and then agency dependent. You may have some type of blood products that you could give. Typically, we're not giving any other types of medications at this stage unless you are pushing blood. At some point, you'll, depending on your agency's protocols, you want to push some calcium with that as well. But this is where we assess our distal pulses. We gain that IV IO access, and then we can, if needed, initiate our fluid boluses and or our blood products. The last stage of our March algorithm we're going to look at is the letter H. This is the last thing that we're assessing and treating before moving into our secondary assessment. And what our H is going to stand for is hypothermia, as well as, this is a two-parter, head injuries. So we are assessing our patient for signs and symptoms of hypothermia and head injuries. So, what is the color, condition, and temperature of our patient's skin? That also ties into our circulation, but we want to think about the environment that we just pulled that patient from, as well as, are they a bleeder? Massive hemorrhage makes you much more prone to hypothermia, and as we all should know, hypothermia is a part of that lethal diamond, that if those four things are correlating, we have a lethal diamond. Our patient might be circling the drain and going towards that light. Hopefully not. Hopefully we treated all of these steps in a good amount of time. But hypothermia, this is going to involve assessing that color, condition, and temperature of the skin. Depending on your agency's protocols, you could be getting a internal rectal temperature to actually identify that patient's internal body heat. And then also assessing for head injuries, checking that pupil reaction, looking for any obvious signs of trauma to the head. Are they altered? Anything like that may guide our treatment. Typically all we're doing for head injuries is bandaging. I mean, agency protocols, you might have a couple of other things in place. We have C-spine precautions, everything like that. But when it comes to our hypothermia for this stage, we also have active and passive warming. Now, active warming is actively applying any sort of intervention to warm that patient, whether that be applying hot packs, a blanket, any kind of space blanket that you might have. Our passive interventions are going to be moving that patient to the ambulance with the heat on, or taking them out of the environment that got them hypothermic in the first place. But we're going to be looking for shivering, getting that internal body temperature, looking for signs of decap BLS on the head. Are they bleeding? Are their pupils reacting? And then Everything else involving that head injury will be assessed in this next step that I'm about to demonstrate on our trauma assessment in our secondary assessment, looking for signs of those basilar skull fractures. Now we will move into our physical demonstration of the trauma assessment. Now in this case, we're going to be actually using my wife as our patient here. And I am going to be kind of gentle because at this point in time, she actually is 7 months pregnant. So I'm not going to be yanking her around. I'm going to be very gentle. If she has to shift around because she's uncomfortable, that's just because she's got our little girl in her stomach there. So as we move into the assessment, the first thing we're going to start on, and for demonstration purposes, and so you can see it, I'm going to kind of move down the right side of her body just so you're able to visualize these things as I do it. So the first stage that we come to is our massive hemorrhage. So we want to identify any signs of bleeding that might be anywhere on her body. Now, if I come up to this side of my patient, it's beneficial to me to start from the top, work my way down to the bottom, and then move around to the other side. But for the demonstration purposes, so you can see, we're just going to move down this side. So the first thing that I'm going to check is the neck. So I can turn my patient's head away from me. I'm pulling apart any sort of tissue here on the neck. I'm identifying and making sure that we don't have any holes here that may have nicked a major artery or the vein. So I'm pulling these apart. I'm getting up in my patient's business, as I talked about earlier, and actually getting a visual on what I'm looking at on my first junctional area. So once I've cleared the neck, I don't identify any major sites of bleeding. I'm going to move down to my extremity. Now, as I move down, I need to expose my patient best I can. So I take my shears, I'm cutting away the shirt here, and this is completely exposed. So the first thing I can do is raise this arm, get it out of my workspace, and I go to the axillary region. Again, pulling apart this tissue, making sure I don't identify any major bleeding. If I do, I apply pressure, get some hemostatic gauze in there, and get somebody to hold pressure for me so I can continue the rest of my blood sweep for my massive hemorrhage stage. So I'm in the business, pulling apart tissue. I don't identify anything here. I need to check for extremity hemorrhage. So I'm squeezing all down this extremity and looking at my hands to see if it caught any kind of blood. I can divide it up into two sections. So I have my upper arm where the humerus is, so I'm squeezing and pulling down, checking for blood. I have the lower part of my arm, the radius and ulna, the wrist and the hand, squeezing and pulling all the way down, checking for blood, looking for signs of bleeding. If I haven't identified anything here, I now move down to the lower extremity. So I need to position my patient in a position to where I can check all of my areas. So I'm going to check the inguinal. I'm going to check the groin. I'm getting in the business. I'm pulling apart tissue from the top of the hip all the way down into the crotch area. I'm pulling tissue apart, seeing if I can visualize any major sites of the bleed. I do this on both sides. Then I have my fourth junctional area, which remember we talked about is that gluteal cleft, the area up under the butt cheek. If I have a supine patient as such, I can cock this leg up, get down next to my patient, and I can actually pull that tissue apart to make sure I don't have any major bleeding down here. And then I would move into my normal extremity blood sweep. So it's important, now that we're down to the legs and they're larger than the arms, I still need to make sure that I'm visualizing everything. So I've cut away these clothes, right? Before I check the inguinal and the gluteal cleft, all these clothes are cut off. Now I'm on to the leg. It's obviously a little bigger and I can't get my hands all the way around a normal adult's thigh. But what I do need to make sure that I do is interlock my fingers underneath the extremity. I'm moving my fingers all the way up to the gluteal cleft and I'm interlocking them under the extremity because I can see this little sliver on top of the leg. So if I interlock my fingers, I squeeze and I pull down to the knee, checking for blood. I'm looking for any major bleeds that were here. Same thing on the lower leg. Interlock my fingers behind, squeeze and pull down. Am I visualizing any blood? And that's the first part of our March assessment. So, once we have identified that we don't have any major bleeds, I'm going to move over here. We move into our airway assessment. So the first thing we want to do is visualize the patient's airway. Before I even open it, do I see anything around the face that may indicate to me that there could be a possible airway injury? So, do I see any soot marks that might indicate to me there might be some kind of upper airway inhalation burns or anything like that? I'm going to open the patient's airway, look inside and see if I can visualize any sort of obstructions, any broken teeth. Did they bite their tongue off? Were they choking on something? Were they chewing on tobacco, gum? The new thing nowadays is nicotine pouches. Are there any of those inside the airway that might be obstructing that movement of air in and out to the lungs? So I visualize, got a flashlight, give me a little more light. I don't see anything. Now it's time to position my patient's airway. So I have two options here. If I am suspicious of a spinal injury, I can have someone come up here and maintain a jaw thrust maneuver to open that airway and maintain it, or I can do a head tilt chin lift maneuver to position that airway. Once I've taken care of my airway, I've ensured there's no actual injury to the maxillofacial region. There's no obstructions inside the airway. There's no inhalation burns, anything like that. I can move into my respiratory assessment. Now, in order to do that, we use our landmarks: neck to navel, pit to hip. So on my patient, I'm going to check everything. I'm going to check the sides, the front, the other side, as well as their back. So I'm interlocking fingers with those bear claws and pulling tissue apart. This is incredibly important, especially with your GSW patients. Bullets pull tissue inward, and it may not be a very obvious entrance wound. So we want to make sure that we identify that hole so we can get a chest seal over it. So I'm interlocking my fingers, actively visualizing what I'm doing, and I'm pulling apart. I'm moving in a methodical movement all the way down to that navel. I'm pulling tissue apart all the way up to the top of the neck. Now, an important consideration with females. Females with large breasts sometimes hang over. Now, we still have to do a good assessment on these females, and that may include using the backside of my hand to lift that breast tissue away to get a good assessment of what might be underneath of that breast tissue that is still an entrance to the chest cavity. So I may need to move that breast out of the way, pull that tissue apart, and ensure there's no holes in that chest cavity. So I'm here, all the way down through my chest, all the way down each side and the front. Next, I need to check the back. So I'm going to be gentle with her in this scenario, but I'm going to roll her towards me. You can just roll with me. I'm rolling my patient, and I'm doing the same thing on my back. A methodical movement, making sure I don't miss any area. Once I've identified there's no holes on the back, I can roll my patient back over. Okay? Now, once I've concluded there's no holes in this patient, I move into my visualization and my auscultation. So I'm down here on the diaphragm. In this case, my little baby girl that's in here. I'm down here on her, and I'm looking up towards my patient's head to visualize that adequate and equal rise and fall of the chest on each side. And then I'll take out my stethoscope. I'll assess the apexes of the lung sounds and the bases and treat accordingly. If I have those unequal breath sounds and I'm suspicious of any kind of pneumo or hemothorax, I can place that needle chest decompression in the second intercostal space, mid-clavicular, right about here, or the fifth intercostal space, anterior axillary, right about there. So that concludes my respiratory assessment. Next, I go into my circulatory assessment. First thing I'm going to do is assess the radial pulses. Are they present or are they not? What's the color, condition, and temperature of my patient's skin? Next thing I'm going to do is initiate my large bore IV access and or IO. I have my tibial plateau or my humeral head. Some agencies, agency dependent, you may carry some kind of sternal IO, but initiating some kind of access to administer the third part of my circulatory step, fluid and blood product administration. Need to go through that IO or IV access. Then moving on to my hypothermia and head injuries. It's important, once I've assessed areas, let's get my patient covered back up. And you can cover them up with a blanket, space blanket, blankets you have from the hospital, extra sheets you may have on the ambulance, towels, whatever you can get over this patient to keep them warm. It will help them clot. Hypothermia inhibits a proper clotting cascade. It's important to keep these patients warm. Even if it's 95 or 100 degrees out like it has been lately, we still have to keep these patients warm because they're much more prone to hypothermia. And if they are hypothermic, it inhibits their clotting cascade when we're trying to stop major bleeding. So it's important to remember that. So I've got blankets over my patient. If this was some type of water rescue or drowning incident and they're hypothermic from the water temperature they may have been pulled from, we might need to apply hot packs to our junctional areas, meaning our groin, our armpits, our axillary region, our neck. We need to apply those to our patient. And then, once we have done our primary assessment or our March assessment, we can move into our secondary assessment. Now, again with the secondary assessment, it's easier to remember how to do things if you do them in a way that makes sense. So in my mind, what makes sense is head to toe. So I will start my secondary assessment, also known as a head to toe assessment. So I'm going to reassess for my head injuries that I went over in my H stage of March. So do I see any signs of decap BLS? In females, are we pulling their hair apart to make sure we don't have any blood dried in the hair? We could be, if in the case of an assault, are there any injuries from a possible GSW we missed? Are there any injuries from blunt force trauma, bruising, bleeding, lacerations, anything that doesn't look right on the head? We're also checking pupillary response. So a pen light to the pupils, are they equal? Are they reactive? Are they sluggish? We're looking for all those things when we're assessing the pupils. We look behind the ears for what's known as battle signs or battle signs behind the ears. Any bruising here is indicative of a possible basilar skull fracture. A flashlight out. Do I have any clear liquid coming from the mouth, ears, nose? Do I see that cerebrospinal fluid leaking from those holes in the body, indicative of, again, a basilar skull fracture? I look around the eyes for paraorbital ecchymosis, also known as raccoon eyes. I'm looking around the eyes for any of that type of bruising. Looking at the nose, is there anything obstructing the nasopharynx for additional movement of air? Looking around the mouth, again, making sure there's no teeth that aren't there that were there before, that maybe were loose and we missed it in our initial assessment. Looking at the mouth, making sure we don't have anything crazy going on there. Moving down to the neck. Do we have any signs of tracheal deviation? Pushing the trachea deviating from one side to the other instead of remaining midline. Do we have any signs of jugular vein distension, possibly from right ventricular failure or tension pneumothorax, cardiac tamponade, anything like that? Do we have any signs of subcutaneous emphysema? Maybe we were bagging this patient and they had a lacerated trachea. Is that air moving out into this lateral space out here? Do we have any of that subcutaneous emphysema? Moving down to the shoulders, do we have a stable chest wall? Are our clavicles stable? Is our sternum stable? Do we have any free floating or broken ribs? We're palpating that rib cage. Again, it's important to reassess in your secondary. We'll reassess those lung sounds at both apexes and bases. Do we still have that adequate and equal rise and fall of the chest on both sides? Are our chest seals, if we placed any of those on earlier, are those still in place? Do we see any additional signs of trauma? Once we've cleared the chest, we'll move down to the abdomen. Do we see any signs of distension, bruising, anything like that? As we palpate each quadrant of the abdomen, we roll our hands, we're feeling for that rigidity. In the cases of a responsive patient, is that area tender? Are they reporting any abdominal pain? Is it rigid? Are we suspicious of possibly some internal bleeding going on? These are all things that we need to keep in the back of our mind based on our mechanism of injury of things that may be going on inside of our trauma patient. So, as we continue to move down, once I've cleared the top half of my patient's body, let's get them covered back up to protect them from that hypothermia. As we move down, we have the hips and the pelvic girdle. Is that pelvis stable? We can reach up here along the greater trochanter, that widest part of the hips, and close that book. And then we can open that book. We push down on those hips. Does it feel stable? If not, we may need to consider applying a pelvic binder to this patient and possibly looking at some major bleeding in this area. We put that pelvic binder on to compress that pelvic girdle, try to stop, I believe it's any bleeding that you have inside the pelvis, approximately 70 to 80% of the time it's actually major venous bleeding. So we apply that pelvic binder to try to compress that pelvic girdle and keep those bones from rupturing any more of the vasculature through them. So once I've cleared the pelvis on my secondary assessment, I move down to the groin and the crotch area. Has my patient experienced any bowel or urinary incontinence that could turn on a light switch for me to consider possibly a major spinal injury? So I'm spreading the legs. Do I see any signs of incontinence through here? In your male patients, it may, again, keep your patient modest, but it may be indicated to possibly use the back of your hand and swipe over the crotch area to check for priapism. And erection in a male trauma patient may be indicative of a lumbar spine injury, an injury to those spinal nerves in the lumbar region of the spine. So we use the back of our hand to swipe for a priapism. And then as we get down to the lower parts of our body, at this point in our secondary assessment, we can now move into our extremity assessment for long bone fractures. We're checking for crepitus. Now, if you would imagine taking your knuckles and grinding them back and forth like this, that bumpy feeling is almost like what crepitus feels like. You'll always be able to feel it, and sometimes, depending on the environment, you can even hear it. So what I want to do is apply opposite pressure on my extremities. So with my top hand, I would apply it at the top of the femur. With my left hand, I would apply it towards the bottom here, just above the knee, and I'm applying opposite pressure to check for any kind of crepitus or give. And then what I'm going to do is just switch positions of my hand and check the other direction. Is that long bone stable? I'm going to do the same thing down here on the tibia and fibia. Opposite pressure, both directions. I'll do the same thing on this arm here. I'm also going to I'll do the same thing on this leg over here. I'm going to do the same thing on the arm. Apply opposite pressure on the humerus over here. Applying opposite pressure. Same thing with the radius and the ulna. If I identify any long bone fractures, I would move into my splinting protocol. Now, through all of this assessment, we have checked our patient from the top of her head to the bottom of her feet. We've done a complete physical assessment on this patient, so we know every single thing that is going on with this patient. We've assessed every area of their body, And as we move through this assessment, we've treated accordingly. Following your agency protocols, guided by a complete primary march assessment, as well as a secondary head-to-toe assessment, gives your patient the best chance at the best possible outcome, which at the end of the day should be our goal in every single one of the patients we encounter on a call.